In this course we will explore the anatomy of the ovary, a paired gland in the female reproductive system and an essential component of the process of human reproduction. We will start with an introduction to the ovary, defining its glandular nature and its role in reproduction. Following that, we will go through the descriptive anatomy of the ovary, focusing on its orientation and situation, the most relevant to the understanding of the process of egg production and fertilization. Next, we will take a closer look at the dynamic structure of the ovary that varies throughout the process of folliculogenesis and oognosis. We will, then, have a look at the supports of the ovary, but more attentively its anatomical relations and their variations throughout the woman's reproductive life. Afterwards, we will proceed to describe the blood and nerve supply and lymph drainage of each ovary before summarizing. The ovary is a sexual paired heterocrine gland. It is intraperitoneal and constitute with the fallopian tubes the adnexa of uterus. The endocrine function of the ovary consists of the production of sexual hormones, when its exocrine function consists of egg production, also known as oognosis. The ovary lies on the lateral wall of the pelvic cavity at a level just inferior to the pelvic brim. It occupies the ovarian fossa, a shallow depression in the angle between the internal and external iliac vessels on the obturator nerve. The ovary is attached to the posterior leaf of the broad ligament by a double fold of peritoneum, the mesovarium. The ovary has a long oblique axis. Its tubal extremity is uppermost and lateral after childbirth, when it is vertical in the nulliparous. The ovary is ovoid in shape, almond-shaped, and firm to the touch, with a hilly surface where the protrusions correspond to the follicles and the depressions to the postovulatory scars. The ovary is whitish-colored and thus easily distinguished from adjacent structures. It has two faces, medial and lateral, two borders, posterior free and anterior, attached to the posterior leaf of the broad ligament by a double fold of peritoneum, the mesovarium, and two ends, superior to bar and inferior uterine. The ovary is smaller than the testis. It is 4 cm long, 2 cm wide and 1 cm thick, and weighs 8 grams. The volume of the ovary increases during ovulation and its weight decreases to 1 to 2 grams after the menopause. Delving into the dynamic structure of the ovary, we will examine the processes of folliculogenesis and oognosis essential to understand this structure and how it ends by producing the female gamete, the egg. The ovary consists of a fibrous stroma made of a central medullary zone containing vessels and representing the hilum of the ovary, and a peripheral cortical zone that constitutes the manufacture of folliculogenesis, covered by a layer of cubical cells, the superficial epithelium, that was originally but mistakenly called germinal epithelium. It has nothing to do with the formation of the primitive germ cells, oogonia, which are derived in the early embryo from endodermal cells of the hingut, yolk sac, that migrate laterally into the developing gonad. By mitosis and growth, the oogonia become primary oocytes surrounded by granulosa cells derived from the stroma. A primary oocyte with a single layer of granulosa cells is a primary follicle. When the granulosa cells proliferate to form more than one layer, the primary follicle becomes a secondary follicle. In a 5-month fetus there are about 6 million follicles, but many degenerate, and by birth there are 1 million, reduced to about 40,000 by puberty. Each month during reproductive life a follicle grows and accumulates fluid, liquor folliculi, to become an ovarian, Gryphian, follicle. The stromal cells surrounding the follicle form the theca. Before ovulation the primary oocyte undergoes meiosis, halving the chromosome number, forming a secondary oocyte. It is this cell, commonly called the ovum, that is discharged at ovulation. The liquor folliculi escapes and hemorrhage occurs into the collapsed follicle. The granulosa cells and some of the thecal cells now develop into a corpus luteum. This persists for 1 week if pregnancy does not occur, or for 9 months if it does. At the end of either time it atrophies and becomes replaced by a fibrous scar, the corpus albicans. Since only about 400 ova can be shed in the course of reproductive life, most oocytes and follicles are destined never to reach maturity, and they can undergo degeneration at any stage of their development. becoming known as atretic follicles. The ovary is free in the peritoneal cavity, although it is not peritonized and is relatively fixed by 3 main ligaments and 1 peritoneal fold. The ligament of the ovary attaches its uterine extremity to the upper angle of the uterus in a distance of 30 mm under the tube. The infundibular-pelvic ligament, also known as the suspensory ligament of the ovary, fixes the tubal extremity of the ovary to the posterior parietal peritoneum and contains the gonadal vessels. It crosses in front the ureter at the level of L3 vertebra and then the external iliac vessels. The infundibulovarian ligament fixes the infundibulum to the tubal end of the ovary and contains the longest finger-like process of the infundibulum. It is continuous with the infundibular pelvic ligament. The mesuvarium is attached equatorially around the ovary, but does not invest the surface of the gland. Let's now go step by step through the intricate anatomical relations of the ovaries that change significantly through the reproductive life. The anatomical relations of the ovary are greatly modified as the ovary folds down to the bottom of the pelvic cavity after childbirth. In the nulliparous, the lateral face of the ovary lies on the ovarian fossa limited at the back by the internal iliac vessels and ureter, forwards by the posterior leaf of broad ligament, at the top by the external iliac vessels and at the bottom by the origins of umbilical and uterine arteries. After childbirth, the ovary is in contact with the sacrum backwards, the ureter and the uterine artery forwards and the upper border of piriformis muscle at the bottom. The medial face of the ovary is in contact with the infundibulum of uterine tube and, on the right, with intestinal coils, cecum and appendix and, on the left, with sigmoid colon. Its anterior border lies on the mesuvarium when its posterior border is in contact with the infundibulum of uterine tube. The upper end is connected to the infundibulum of uterine tube and mesosalpinx when the lower end lies 2 cm above the pelvic floor. The ovary is supplied by the ovarian and uterine artery. The ovarian artery is a branch of the abdominal aorta just below the renal artery. It runs down behind the peritoneum of the infracolic compartment and the colic vessels, crossing the ureter obliquely, on the psoas muscle. In the pelvis, it crosses the brim of the pelvis and enters the suspensory ligament, formerly the infundibular pelvic ligament, at the lateral extremity of the broad ligament. It, then, gives off a branch to the uterine tube which runs medially between the layers of the broad ligament and anastomoses with the uterine artery, and it ends by entering the ovary in its tubal end. The anastomosis between the ovarian artery and the ovarian branch of the uterine artery forms the infraovarian arterial circle. 3 to 4 branches arise from the upper side of the infraovarian arterial circle supply the ovary. The microcirculation of the ovary consists of 3 orders of arterial capillaries and forms a perifollicular plexus. The ovarian veins form a plexus in the mesuvarium and the suspensory ligament, the pampiniform plexus like the testis. The plexus drains into a pair of ovarian veins which accompany the ovarian artery. They usually combine as a single trunk before their termination. That on the right joins the inferior vena cava, that on the left renal vein. The lymphatics of the ovary drain to para-aortic nodes alongside the origin of the ovarian artery, just above the level of the umbilicus. L2. Clinical observation shows that it is also possible for lymph to reach inguinal nodes via the round ligament and the inguinal canal, and to reach the opposite ovary by passing across the fundus of the uterus. The nerve supply is ensured by sympathetic, vasoconstrictor fibers reach the ovary from the aortic plexus along its blood vessels. The preganglionic cell bodies are in T10 and 11 segments of the cord. Some parasympathetic fibers may reach the ovary from the inferior hypogastric plexus via the uterine artery and are presumably vasodilator. Autonomic fibers do not reach the ovarian follicles. An intact nerve supply is not required for ovulation. Sensory fibers accompany the sympathetic nerves, so that ovarian pain may be perumbilical, like appendicular pain. Take these messages home. The ovary is the organ of egg production. It occupies the shallow ovarian fossa and thus has several peritoneal, visceral and vascular relations that change over time. In addition, the ovary is free in the peritoneal cavity and benefits from a rich anastomotic blood supply that leaves safe the ligation of uterine artery, particularly in the management of postpartum hemorrhage. Lymph drainage is ensured mainly by paraortic nodes and can be variable through the reproductive life.